Good afternoon. Thank you all for inviting me here today. I'm delighted to be able to speak to you about a topic that's near and dear to my heart, immune deficiencies, namely primary immune deficiencies. So we're going to review a case, then on to Immunology 101, which will help us to better understand B-cell deficiencies and antibody deficiencies, and then finally an overview of treatment. So let's start with our case. A 30-year-old female presents in your office with complaints of frequent respiratory tract infections, including recurrent sinusitis, recurrent pneumonias, all which have required treatment with frequent and prolonged courses of antibiotics with modest effect. She tells you that she's seen ENT in the past and a CT... This one? Okay. Is that better? Can you hear me? Better? Okay. So she's seen ENT in the past, and a CT of the sinuses looks like this. Shows pansinusitis, and this was treated with sinus surgery. I'm guessing this sounds familiar to many of you. She reports that about 10 years ago, she was hospitalized for pneumonia and required IV antibiotics and was sent home with IV antibiotics as well. She has a history of IBS, and her family history is significant for a brother with asthma and recurrent sinus infections as well. Routine lab workup revealed low total protein, normal albumin, normal number of T cells, and decreased number of B cells. Quantitative immunoglobulins were significant for low IgG, low IgA, and normal IgM. In an effort to boost immune response, the physician gave Pneumovax. 4 weeks later, post-vaccination titers were hardly improved as compared to pre-vaccination titers. The diagnosis here is common variable immune deficiency. What are the diagnostic considerations? We have a patient with a history of recurrent infections requiring frequent and prolonged courses of antibiotics. The patient has an inability to mount antibody response despite very recent vaccination, and an elusive GI diagnosis. So common variable immune deficiency. Common because it's the most common immune deficiency worldwide. Variable because it varies in its presentation from recurrent infections to autoimmune disease, allergic disease, and lymphoproliferative disease. An immune deficiency. So what you see here in common variable is that you have two classes of antibodies that are low. In this patient, you can see that IgG and IgA are low. Your IgM is normal. And the quality or the function of your antibodies is impaired. There are several gene defects associated with common variable immune deficiency, and the mainstay of treatment is IVIG or immune globulin replacement. So why do we care about primary immune deficiencies? We care because early diagnosis lends to timely treatment, which is effective in improving the quality of life of patients and decreasing the morbidity and mortality of these patients. There are cures for some of these diseases, and last but not least, they are not rare. If you take nothing else from today's talk, please remember this slide. Primary immune deficiency diseases affect more than 10 million patients worldwide. They are 5 times more common than cystic fibrosis, 4 times more common than hemophilia, twice as common as childhood leukemia and lymphoma combined, and as common as multiple sclerosis in the United States. There are more than 200 types of primary immune deficiencies, and more than 270 genes have been identified. Primary immune deficiency in adults are almost as common as they are in children, but sadly, most people consider them a childhood disease. And for that reason, it takes almost 20 years from the onset of symptoms to diagnosis of these diseases. These patients are presenting every day in doctors' offices with common complaints of recurrent infections. They can also present with non-infectious complaints, which include allergies and autoimmune disease. The most common primary immune deficiencies are B-cell deficiencies, also known as antibody deficiencies. The second most common are combined immune deficiencies, so this involves both T cells and B cells. And some of the least common are complement deficiencies. So let's take a walk through some basic immunology to help us understand a little bit better about antibodies, their production, and why defects are important. The term immunity is derived from the Latin word immunitas, which refers to protection from legal prosecution offered to Roman senators during their tenure in office. The key element of the immune system is protection against pathogens. But we cannot forget that the immune system also is important in fighting allergic disease, cancer, and is important in autoimmunity. So what happens when our immune system fails? Primary immune deficiencies present with the paradox of failure to respond to non-self and overreaction to self. Thereby, patients suffer from increased susceptibility to infections. They suffer from allergic disease, cancer, and autoimmune disease. There are two arms of the immune system, the innate immune system and the adaptive immune system. The innate immune system is considered the first-line defense. The innate immune system does not do any immune memory, nor can it recognize self from non-self. The constituents of the innate immune system include natural killer cells, which help us fight viruses and cancer, dendritic cells, which actually help to shape the immune system. An example is they can help differentiate T cells to do different jobs. The innate immune system also is comprised of monocytes, macrophages, and neutrophils, which function to phagocytose antigens. And finally, the complement system, which is a robust component of inflammation. The adaptive arm of the immune system is a more sophisticated arm. This arm helps us with immune memory, one of its primary functions, and distinguishing self from non-self. T cells and B cells are the main cells in the adaptive immune system. T cells are all recognized by cluster differentiation 3 on the surface of their cells. Additionally, they're split into two teams on a basic level. Killers, recognized by CD8 positive on their cell surface, and helpers, CD4 positive cells. These cells are important in helping us to fight viruses, fungi, parasites, select bacteria, and are incredibly important in transplant immunology. B cells carry CD19 and CD20 on their cell surface and are vital for antibody production. They help us to fight most of our bacteria and can help us fight some viruses like echovirus. So when the immune system encounters an antigen, as you all remember, the innate immune system, our first line of defense, takes place. We have an increase in peripheral cells, including natural killer cells and inflammatory mediators, for example, interferon gamma. We recruit monocytes, macrophages, and neutrophils, and after some time, the adaptive immune system kicks in. Together, we're able to eradicate infections and retain immune memory. So let's talk about antibody function. What do antibodies do? We know they bind to microbes. They help us to neutralize bacterial and viral toxins. They prevent the attachment of bacteria to mucosal surfaces, transfer immunity from the mom to the newborn, activate complement to recruit inflammatory cells to the site of infection to help us fight antigens, and prevent reaction to self-antigens. So in this cartoon, what we see is our antibodies and all their different functions. So once again, they help us to neutralize microbes and toxins. Secondly, they help us with opsonization. What is opsonization? Opsonization can be thought of as immunologic ketchup. So what antibodies do is they put immunologic ketchup on antigens and make them more delectable or desirable for our phagocytes to eat. Another thing our antibodies do is antibody-dependent cellular cytotoxicity. What is this? This is when an antibody binds an antigen and actually brings it near a natural killer cell to allow the natural killer cell to do its dirty work for it. Finally, antibodies are strong binders of complement. And when complement is activated, massive amounts of inflammatory cells are recruited to the site of infection and antigens are lysed. So let's talk a little bit about the structure of the immune globulin. As you can see, this is IgG. The structure here is Y-shaped. Let's see if it can point it out. Okay. So on the inside of the Y, you see V and C, H. Those are the heavy chains of the antibodies. And on the outside of the Y, you see V and Cl. Those are the light chains of the antibodies. On the tops of the Y are the antigen binding sites. So how do we make antibodies? In the bone marrow, stem cells go to form pro-B cells, which then undergo gene recombination and place the heavy chain on the surface of the pro-B cell, and it becomes the pre-B cell. Moving out from the bone marrow into the periphery, gene recombination occurs once more, and the light chain is placed on the surface of the B cell. During this time, there is also negative selection, where deletion of self-reacting antibodies takes place. Finally, we have activation, proliferation, and differentiation of the B cell to be a mature B cell. In all these steps, you can see that if there are any glitches, you're going to have either decreased number of B cells or defective antibodies, or both. So now we have our mature B cell that's naive. When it encounters antigen, it recruits T cell help, and then the B cell is activated. It then undergoes clonal expansion and class switching. Class switching allows the IgM to switch to IgG, IgA, or IgE, depending on the nature of the antigen. Are all antibodies created equal? No, they are not. As you can see here, IgM is the largest antibody. It makes up about 8% of the total immune globulin and is present primarily in the blood. It functions to distinguish self from non-self and plays a very important role in complement activation, and that is due to its large size. Its half-life is about 5 days. IgG is in the top left corner. It's considerably smaller. This makes up 80% of our immune globulins. IgG is extremely important in immune memory and reactivation. For example, with hepatitis B, you'd see increased IgG levels. IgA is a dimer and is important in mucosal immunity. It prevents bacteria from adhering to mucosal surfaces. Subclass 1 of IgA is present in the upper respiratory mucosa and subclass 2 in the gut mucosa. IgE is allergic antibody. This has the shortest half-life and makes up the least amount of your total immune globulin, less than 1%, and a good amount of it is located in the subcutaneous tissue. IgD, we just do not know that much about. It plays a role in periodic fever syndromes. We can talk more about that later if you like. So what are some examples of antibody deficiency syndromes? X-linked agammaglobulinemia. This patient is a male patient that presents with recurrent infections, typically sinopulmonary or GI infections. They have absolutely no antibodies. Some have normal B cells and some have decreased amount of B cells depending on the gene defect involved. Common variable immune deficiency. This is the most common immune deficiency. This is what our case was about earlier. Presents with two classes of low antibodies, typically G and A being low, with poor functional antibodies. Another one I want to point out here is specific antibody deficiency. These patients also present with recurrent infections. However, upon first look, their immune globulins are completely normal. These are the patients that, when you're comparing pre- and post-vaccine titers to Pneumovax, have incredibly impaired function of antibodies. So how do these patients present? Once again, recurrent respiratory tract infections, recurrent ear infections, sinus infections, pneumonia, and finally, many of them have end organ damage, so bronchiectasis. Some often will present to your office with pulmonary infiltrates or granulomas. They also often have GI manifestations, including malabsorption, ileitis, colitis. Many patients will wander from doctor to doctor with complaints of chronic diarrhea. When the stool is cultured, it will classically be positive for Giardia, Cryptosporidia, or Campylobacter. Please think immune deficiency when you see these patients. So how do we treat these patients? The mainstay of therapy is immune globulin replacement therapy, or IVIG. Other treatments include gene therapy and stem cell transplant. Today we'll focus on IVIG. So what is IVIG? Immune globulin replacement therapy is essentially giving these patients back what they're missing. So you're giving back protective antibodies. As you all know, it is not possible for one person to have protective antibodies to every antigen that is out there. So what is done is about 50,000 donors donate blood, plasma is extracted, and immune globulins are pooled. These are purified and nanofiltrated and administered IV or subcutaneous to patients. Purified IG products have been used for over 50 years, but used to be IM administration. The important thing to remember about immune globulin replacement is that we're not fixing the problem at this point. Right now, all we can do is actually give the patient back some antibody protection. So, for that reason, this is a lifetime treatment. And for now, we have not figured out a way to prolong the half-life of our antibodies. Therefore, these antibodies are metabolized in the patient's system just as if they were their own. And so typically, antibodies are given once every 28 days. There are subcutaneous preparations that can be given once a week, and more recently, the FDA has approved a once-a-month subcutaneous treatment that's facilitated by enzymes. So to recap, the warning signs of immune deficiency in adults are as follows, and this is put together by the Jeffrey Modell Foundation for Primary Immune Deficiencies. 2 or more new ear infections in 1 year, 2 or more new sinus infections 1 year that are not related to allergy, 1 or more pneumonia per year for more than 1 year, chronic diarrhea with weight loss, recurrent viral infections, recurrent need for IV antibiotics to clear infections, recurrent deep abscesses, persistent mucocutaneous candidiasis, recurrent infections with bacteria that are typically harmless, and finally, a family history of primary immune deficiency. So please remember that these are not rare diseases. These patients are presenting with common symptoms. They just don't respond that well to antibiotics. They can also present with unusual infections, and they can also present not with infections, with cancer, with autoimmune disease, or with allergies. Advances in treatment are being made, and that, coupled with our better recognition of these patients, will help us to provide the highest care we can. Thank you for your time. Any questions?
Can you say a word about the toll receptor system?
Yes, absolutely. So there are defects in toll-like receptors. Basically, these are receptors that play a major role in inflammation. So there are periodic fever symptoms, for example, called TRAPS, where you have defects in toll-like receptors. The treatment for these are different. These are inherited through families. The genetics of this has been identified very well and can be traced through families. There's a large cohort in Sweden, actually. One of the main treatment areas around here is actually in San Diego. Cryopyrins have become a hot area of research. There's a physician in San Diego by the name of Hal Hoffman who's actually discovered one of the genes related to periodic fevers in TRAPS, so TLR receptor defects. Yes?
What is the status of asymptomatic monoclonal gammopathy of undetermined significance?
What is the status of MGUS?
Yeah.
So from an immunologist perspective, we often see MGUS, and what we do is if I have a patient that comes in and I look at their immune globulins and, for example, they have an elevated IgM, the next thing I'm going to do is protein electrophoresis. If there are no monoclonal proteins identified, then I continue to follow them regularly to determine if there are any changes or associated symptoms. Typically, these patients will remain healthy, and it will simply be a lab finding, but many times those that are not will end up with the hematologist oncologist. Does that answer your question?
Yes and no. You didn't mention multiple myeloma.
Mm-hmm.
Does it go on to multiple myeloma within 6 months or 16 years? How does it happen?
So it can go on to multiple myeloma, and that is variable in terms of the timing for that. Some do and some don't. Yes?
Slightly off this topic, would you speak to what appears to be almost an epidemic of peanut allergy in the United States compared to other countries?
Sure. So there's a couple things with regards to this. The first thing is the hygiene hypothesis, which you've probably heard of. So the immune system's essentially bored, so it's more allergic than non-allergic. So you have an increase in the Th2 pathway versus the Th1 pathway. People are more allergic. The second thing that we've learned from the most recent study in the New England Journal of Medicine called the LEAP study is that the recommendations set forth by the American Academy of Pediatrics in 2008 to delay the introduction of peanuts has actually created this phenomenon of increased peanut allergy in the American population. There was the LEAP study actually compared children in Israel and children in the United Kingdom, and children in Israel actually receive something called bamba at a young age, which is a peanut mush. They get around 3 to 4 months of age, and children in Israel very rarely have peanut allergy. And in the United Kingdom, they operate similarly to the way we do according to the AAP, the old AAP guidelines now. And so the incidence of peanut allergy is considerably higher. So the research was done, and this was found to be one of the main reasons. So as of a few months ago, the recommendations for introduction of peanut has actually changed, and so it is recommended to actually introduce at 4 months of age. Is that helpful? Okay.
It sounds like grandparents were right in modern parents, and modern parents
Always.
don't have it.
Yes.
subclass deficiency and which need to be replaced, please?
Sure. So IgG is made up of 4 subclasses, IgG 1, 2, 3, and 4. IgG 1 actually comprises the largest amount of total IgG. Subclass deficiencies that we tend to work up and provide replacement therapy for include 1, 2, and 3. IgG4 becomes more important if it's high rather than when it's low. IgG 1 and 2 and 3 subclass deficiency not only present with recurrent infections, but they also present with a variety of allergic diseases. The replacement therapy works exactly the same way as it would with any of the ones that we talked about. We'd still do Immunoglobulin in the same fashion, and we'd follow them up every 3 months to make sure that their levels were coming up and that their clinical symptoms were improved. Does that answer the question?
At what level in particular? See, the problem is we run these things off and then we get something, maybe a 1 or a 2 that's down by, let's say, a percentage, 15%. When does it matter?
Okay. So if everything else is normal and it's just a subclass that's low, there's 2 things that I typically do. So I'll look to see whether it's within 2 standard deviations of the normal for that lab. And then the second thing is double checking that it's a reproducible result. So typically I will say probably 50% of the time, checking it twice, you'll get a normal level. And so it may have just been a lab error. So before, you're pursuing treatment, absolutely double check. And if it does happen to remain low, then treatment is warranted should the patient have clinical symptoms, and it is effective. Mm-hmm.
Just to follow up with that question, one of the things that we do as an allergist as well is check the, I don't know if you mentioned this back in, but is to use Prevnar to measure pneumococcal antibody levels before 4 weeks, give a Prevnar injection, and 4 weeks to measure the response. If the patients get at least a 70% increase in 70% of the antigens, you get a 4-fold increase, then your immune system is functioning pretty well. That's a finding that's almost independent of the level. The other question I mentioned is I don't know of any study that might do of IgG2 deficiency, which has been shown to be improved by IgG. That's been somewhat controversial.
Sure. So to answer the first question, typically Pneumovax is used simply because it's a pure polysaccharide vaccine. And what you're doing then is you're isolating your B cells. So when you're isolating your B cells, you're isolating your antibody-producing cells. So what you would do is you'd obtain pre-vaccine titers. You'd vaccinate with Pneumovax. 4 weeks later, you would check your post-vaccine titers. Depending on the numbers that you have pre-vaccine, you want to see a 4-fold rise or a 2-fold rise in numbers. If, for example, you're using Quest Labs and your pre-vaccine titers are 2 or below or under 2, then you're looking for a 4-fold rise in titers. And yes, 60 to 70% is what you're hoping for adequate response, certainly. With Prevnar, it gets tricky because we're recruiting T-cell help at that point, and so it's very difficult to isolate pure polysaccharide response, so exactly what your antibodies are doing. A lot of times to check T-cell function, we'll check other vaccines like diphtheria, tetanus, or even do intradermals to Candida, tetanus, or mumps. With regards to IgG2, so there are some studies out there. I can give you those papers, some that I worked on with my mentor in fellowship.
Would you say it's more dangerous to treat this type of patient like a common variable patient with biologics like Monroe or Mercury?
It's a really good question. So there's not a lot of good data on that, is what I will say first. But that being said, as we talked about, common variable patients will present with autoimmune disease, lymphoproliferative disease, recurrent infections. So it's not necessarily a bad thing, and there are some patients that I have of my own which you do require more than one, for example, biologic in play. So it's not, as long as they're being replaced with immune globulin therapy, you're providing protection against the immune suppression that you may be causing with a biologic.
As a pulmonologist,
Yes, so there have been a few genes actually identified recently which interfere with interferon gamma receptor, and with macrophages. So there's a couple papers that just came out. I actually had a patient with a disseminated MAC infection. So this patient was sent to the NIH and actually had a novel gene defect in the interferon gamma receptor. So I'd love to talk to you more about that. Mm-hmm. Hey.
What do you recommend for primary care doctors to do to screen our rather large portion of patients who seem to have frequent infections? Before sending them off to a specialist, what would be a good screening panel to order?
So I would CBC with diff, looking for CMP. When you saw the first case where the patient had total proteins low, normal albumin, what you knew right then and there is that the globulin was low. So that's kind of an easy thing to do. Other than that, just looking at immune globulins, G, A, M, and E. This way you're looking at immune deficiency and potentially allergies as a cause. And if you decide to pursue anything else, considering titers for vaccines, including tetanus, diphtheria, and Haemophilus. And I would say that before you vaccinate to either Prevnar or Pneumovax, consider obtaining pre-vaccine titers, just in case you go down that road. Anybody else?
Would you comment on isolated IgA deficiency and what level is significant?
It's a really good question and a super hot topic of debate. So selective IgA deficiency is the second most common immune deficiency worldwide. Most people are completely asymptomatic and it becomes an incidental finding. We're seeing a lot more these days because people are doing celiac panels. And so what I will say about that is that although they're very common, it's about treating the patient, not the number at that point. So if we find a patient that has selective IgA deficiency and they're completely healthy, so no sinopulmonary infections, no GI problems, we follow them every 6 months to a year. What we're looking for is, are they going to develop infections, or are other antibody levels going to drop? Are they going to become a common variable? In the selective IgA deficient patients, you absolutely want to check for your antibody response. So if you have a patient with selective IgA deficiency, check to see, do they respond to Pneumovax appropriately? And that will give you a lot of answers as to what is this patient going to turn into if they're not already symptomatic. Is that helpful?
Yes, and what level is significant? Because I, for example, screen patient for celiac, and I get a level of 70 or 80 milligram per deciliter. What is the cutoff point, that you send patient to you? In asymptomatic patient, no history of GI or pulmonary or sinus infection.
So it's a really good question. There's no good data to suggest that there's certain levels where you should send someone to be seen or not. If they're symptomatic, they should be worked up in more detail. Always, when interpreting the lab data, within 2 standard deviations of normal is completely fine, just needs to be observed. IgA levels that are significantly low, under 10, need to be watched very closely. The problem with these patients is that IVIG can actually be contraindicated in these patients because you can have, there are reports of anaphylaxis in patients like this. Anybody else? All right, thank you very much.